Tonight, we are excited to present a panel of CGMH leaders to discuss some of the exciting things that donors have made possible at your hospital, the hospital that is here to care for all of us. Please join me in welcoming our amazing leaders this evening. Okay, leaders. Staff, Dr. Gillian Yeates, Chief of Dr. Gregory Devet, Chief of Emergency Medicine, Program Director, and Michael Lacroix, the President and CEO of your hospital. Please welcome. So thank you all for joining us this evening. We're going to be asking individual questions of each of the medical leaders here, and they'll be responding. And I'm going to start with you, Dr. Devet. So Dr. Devet came to Collingwood as a family practice resident in 2011. What was it, Greg, that drew you back to Collingwood to practice? And why did you choose to practice emergency medicine?
Thanks, Jory. Thank you very much for everybody being here this evening, and our apologies in advance if we don't know where to look, because we're not really used to this. So I came here as a resident after medical school. During my interviews, I was told at that time they gave free ski pass to the residents, and the doctors really enjoyed playing hockey, and that's true to this day. And I really enjoyed my time in residency. At that time, going through family and specifically going through Emerge, I found the quality of the care we were giving in Emerge and the quality of the Emerge docs to this day, but at that time as a resident, I was really inspired to work with these people like Dr. Guscott, Dr. DaCosta, Dr. Chisholm, Dr. Booth, who taught me. I just kind of was gobbled up in wanting to be like them, to provide the care like they provided. So also then, you meet your wife here, you get involved in the community's great. I mean, I don't have to go on with that, it's just a wonderful place to live for everybody. It was kind of a no-brainer. This is where I was going to be working and living, and I've really enjoyed the challenges of working here in the Emerge in Collingwood. It's a great Emerge to work in.
Wonderful, thank you. Dr. Guscott, we're going to go to you next. We know that you've got a keen interest in teaching, and I believe you also came to Collingwood as a resident. Is that true?
I was also enticed by the ski passes. So
can you tell us a little bit about the Rural Ontario Medical Program that's based at CGMH and what benefits it has for our community?
Yeah, I'd love to. So my backstory on how I ended up in Collingwood was I was a medical student in Hamilton, actually with Dr. Lisi. We were in the same class, and an email went out saying, is anyone interested in doing their core family medicine rotation in Collingwood? I'd never really spent any time in Collingwood. And this is in the early 2000s, and a really interesting thing is kind of happening in that period, which is up until that point, you pretty much had to do all of your training in Hamilton, Toronto, London, Ottawa, Kingston. That was basically where all of medical education was happening. And right around there, people started to recognize that there was really great teaching and learning opportunities in the community. So I'm excited to say I was really at the right place and the right time when that started to happen. The Rural Ontario Medical Program had been here for some time, and it's basically a placement agency, amongst many other things, to help facilitate learners coming to smaller communities to make that easier, because at the time, everything was set up in the big cities. It was actually quite challenging to get out of the city for training. So the Rural Ontario Medical Program facilitated me and I think 6 or 7 of my classmates to come up, and we spent 2 months in Collingwood. And in that group, I think 2 or 3 of us have ended up, practicing here, which is a pretty big percentage of a small group like that. But I think the idea behind the Rural Ontario Medical Program is if you get learners, at a young stage in training into the community, they see how wonderful it is. They see how great it is. They see the mentors and in the community, and that becomes really attractive. So that's certainly what happened for me. I came as a medical student, and then the year before I graduated, McMaster started a residency program here in Collingwood. So that's the program that I trained through and that Dr. Devet trained through. So we did 2 years of family medicine here in the community, and once you get involved in the community like that, and you're here for 2 or 3 years, it just becomes really easy to stay and really, really hard to leave. So community training programs, I think, have been a huge piece of the success of our hospital and our community. If you go through the list of the doctors who have joined our community in the last 20 years, a huge proportion of them have trained here or spent part of their training here, and that's thanks to the Rural Ontario Medical Program.
So you're training some of those new physicians yourself. Many of you, I think all of you, are training physicians. No, Mike.
We don't let Mike do that.
We leave that to the professionals, Mike. You can deal with the accountants. What's your role in training those new leaders in medicine?
Yeah, so I've been involved in sort of clinical instruction since early on in my clinical practice here, and really decided that medical education was one of my true passions outside of clinical medicine. So I teach learners pretty much every day. I have a resident or a medical student with me almost every day, and for the last 12 or 13 years, I've also been the residency program director for McMaster's Family Practice Anesthesia Residency. So one of the few opportunities to run a residency program from a community, so that's pretty exciting and has worked out really well for me. And then I do a lot of education for practicing physicians, for nurses, for RTs, for interdisciplinary teams. So that's kind of my other non-clinical passion. I give talks at conferences and I run workshops and simulations. So my medical education is my second love.
Can you tell us a bit about the simulation program? I mean, you've built an extraordinary simulation program especially for a small rural hospital. Can you share why your teaching model in a rural hospital is so important, not just at CGMH, but for hospitals across the province and across the country?
Yeah, I'd love to. So simulation education, I'll tell you a little bit kind of what that's all about. The easiest analogy is if you think about the airline industry. So if you're a pilot, you don't learn to navigate when one of your engine goes out by knocking out your engine with 300 people on board and try to figure it out. They go through simulations. They spend every X amount of months go back into the simulator to train on those things. And medical education was really slow to that game. But 25 years ago, that started to be a bigger and bigger part of medical education, is integrating simulation. So basically what I do is I take your kind of once in a career or maybe once a year or once every 5 year kind of like real disasters, really awful things that can happen, and I simulate them. We have I'll talk a little bit about our program in a sec, but with the equipment that we have, we're able to make that look and feel pretty realistic. And my real passion in simulation education is less around the technical and more around the group dynamics. So I'm really interested in communication. I'm really interested in leadership. I'm really interested in, if Gillian and I are in a case together, or Michael and I are in a case together, how can we optimize the performance, our own performances, but also the performance of the team? How do we communicate with our nurses and RTs? How do our nurses and RTs communicate with us? Breaking down, the old models of hierarchical, leadership in an operating room where the surgeon is the boss and the anesthetist, everybody knows the anesthetist is actually the boss, but the old models of hierarchical communication, what we know is that doesn't work. The airline industry learned that decades ago that does not work in crisis. So my passion in simulation is around, how do we level that communication? How do we make a nurse who actually knows the right answer for how we solve this problem? How do we make it accessible for them to come forward and and make a suggestion? How do we receive that information? So those are the things that we do. The way that we came about building our program, I had done simulation work for about a decade out of the Northern Ontario School of Medicine in Sudbury. I'd been involved in a project there, and it just sort of dawned on us one day, like, why are we traveling, to the north to these universities? I was doing it at McMaster as well in Hamilton. Why are we traveling to these other places when we have the expertise to do it in Collingwood? And the other piece that was really missing amazing is when you go and do a simulation in Hamilton, for a trauma gets called and the anesthesia resident comes and the anesthesia staff comes and the general surgeon comes and the general surgery resident comes and the ENT surgeon and 40 people show up for that trauma. Unfortunately for Greg, when he has a trauma in the emergency room, 40 people do not show up to help him with his resuscitations. So I really felt like we needed a homegrown solution. We needed a program that attended to our needs, to our challenges, from a resource point of view. So that's sort of where it came from for me, and we were so fortunate. Our simulation program is entirely funded on donor dollars, and we had some really, really progressive, forward-thinking donors who put a ton of trust in me, and I'm so thankful for what they were able to do. It felt like a bit of a pie-in-the-sky proposal. Jory had faith in it from day one, but felt like a bit of a pie-in-the-sky proposal because we really wanted to build, not just buy a mannequin and throw it out there, but really build a program around that. And thankfully, we've been very successful both in-house and we've exported our program. We take it on the road and go to other communities that wouldn't have the resources that we have and run simulations in their hospitals as well.
Thank you. Dr. Yeates. Most of us think about South Georgian Bay as being a retirement community, but you know that not to be true. Can you give us a bit of a sense of how the obstetrics program in Collingwood has grown over the years and how the future looks for obstetrics?
The babies keep coming. So when I first got here in 2000, before these people were in med school, we had a primary level facility that was run by family doctors. We had 2 general surgeons who did cesarean sections, and we didn't do any high risk. All our high risk patients were sent out of town, and for high risk, that would even be our insulin dependent diabetics or our twins. And so we have grown that department by increasing our catchment of people in this area, by providing more services to a variety of people, and doing all that until now. We deliver between 500 and 600 babies a year. My first 8 to 9 years I was by myself in practice and worked with the family doctor, so my biggest stretch of call was 12 weeks. And
Wow.
in my first trimester of my second pregnancy, I delivered 42 babies in the month of March and did not sleep through the night. But we have grown our program from that because we're able to provide more services. We have trained our nurses to increase what they're able to do. We've empowered our staff. We've done more OB, so that is based on communication and education and then teamwork, and based on safety from the airline industry, where it's breaking down hierarchies, calling people by first names, empowering people to speak, having everybody at a baseline level of knowledge, and really doing teamwork. And I love our OB team. I think this labor and delivery department is the best one I've ever worked in, and our numbers back that up. And so I'm super proud of that.
Dr. Lisi, you've been quiet. What would people in our community be surprised to learn about the work that you do, both as the Chief of Staff and as a General Surgeon with, I know, a really keen interest in innovation?
Thanks, Jory. I think it's a very busy life, and I think that it's important to know that when you're in a community like this, it's not just a job. It's really it becomes a part of you. And I think everybody up in the panel, you hear Dr. Yeates just speaking to when she had her children and participating in delivering. It's really a lifestyle, and it's something that we just love to do, and that's the most important thing. You have to love what you do, and you have to have 4 basic pillars. You have to be providing great quality. So what you do, you have to care about what you do, and you have to invest yourself to do the best that you do, and physicians are usually a type A type of people. We want to be the best at what we can be. You also need the right people. That's probably the most important thing. In both my role as a general surgeon, we need the nurses that we have here that are excellent. We need the anesthetists who are the bosses in the operating room and do great things. Thank you, Jesse. I will. And we need our learners, our medical students, our cleaning staff, our folks that take the instruments and make sure that they're sterilized properly. We need our greeters, our volunteers who help to take people from one place to another. We need everybody, and it's the people that's the special ingredient, I think, here in Collingwood. We also rely upon partnerships. You've heard stories about the Royal Internal Medical Program. We are integrated with that program. We need them, they need us. Our learners that come through, 75% of the learners that come through the Royal Internal Medical Program at Collingwood will stay in Collingwood and work. We know that in Collingwood, we have about 151 learners that come through our institution in a year, and Collingwood's physicians provide 200 months of hours of training. So that's a quantity. What does that really mean? Well, if you compare us to, say, I hope there's no one from Midland in the room, but let's say they'll have about 48 learners that go through, and they'll have about 75 hours of Fonty training. So we're punching well above what we're doing compared to others. Compare it to Barrie. If you look at Barrie, they have, I said, we have 200 months of training that we're providing. They're providing 250 months of training. They have 450 physicians. We have just around 100. So put this in perspective for what we're doing compared to what others are doing. And it's because of the folks that are up here and who they've trained. And you heard Dr. Devet say that Dr. Guscott trained me, and Dr. Devet's training others who have come along, and it just spirals down and down, and then that's that cycle that it's those individuals that you want to keep who become ingrained in the community, as I said from the beginning. And then on top of all of that is the innovation sauce. And so that's the best. That's sauce. It can be spicy. It can be sweet. It can be so many different things. You heard about the equipment that we can get that provides innovation. There's also this past year, the Giving Circle, thank you Foundation and Giving Circle, provided something called a Molly equipment in the surgical world. This is a little magnetic clip that gets placed into a breast for breast surgery, and we can localize the breast cancer much more easily and not rely upon having to put a wire through the morning of the surgery, and we can do it up to 30 days before, which makes things much more convenient for the patient, which makes things much more convenient for scheduling, and improves quality in that fashion and satisfaction for the patient. In 2015, we were one of 15 hospitals in the province to join something called the National Surgical Quality Improvement Program. This was first started by the American College of Surgery, and it's spread into Ontario, and we jumped on board, became one of 15 in the province, and over the years now there's about 90 to 100 other hospitals that have joined this program, but we were in there first, and I always like to get in there first for all of these things. We are working on additional innovations, digital technologies, mobile platforms, having a patient follow from where they're at home to figuring out what they need to do prior to a surgery, having a surgery, then going home and being using an app to help them work through some of the post-operative questions and situations that may arise. We're pulling together people in our annual research day. I'm going to put a plug in for our annual. I always do this, Jory. Sorry, I steal the stage. And this annual research day we have is this year's on planetary health. We're focusing on planetary health, and so it means making our hospitals green. Participating in provincial initiatives, national initiatives, and international initiatives to lead the way to reduce certain gases that we use in an anesthetic room so that it doesn't pollute the environment. The amount of waste in the packaging that a sterile equipment comes in, the types of drapes that are present that we don't use, to having a patient instead of giving them a plastic bag to keep their items in, tell them to bring their own bag in to keep their items in. It's these simple items that we're doing. It's the simple things up to the more complex things. And that's just kind of a snapshot of some of the items, and there's so much more, but I could go on.
Very exciting topic. Dr. Yeates, back to you again. Dr. Lisi and Dr. Guscott have spoken about some of the innovative things that are happening at CGMH. And you've stated that your team mainly delivers uncomplicated pregnancies, but that's not always the case. How do you prepare for the unexpected in your department?
Well, we will have anybody walk through the door, so we can have to deal with very premature babies. We can deal with the unexpected term baby that doesn't adjust well to life outside of the uterus. So we can have very extensive resuscitations. And the difficult part in our job is everybody thinks everything's going to be peachy and perfect. And it's not always, and it's scary as all get out when it's not. And so rather than panic, you sim these out. So we came up with scenarios, we do sims, by that, you walk in, you have everything set up as a resuscitation, you have all of your equipment, and then you are given a story, and then you are given this model of a baby, and that is very realistic looking. And you start and you go through all the things, and if it's not right or if it falls apart, well then you stop. We talk about it, we start it again, and we keep doing it, we keep doing it, we keep doing it until you're comfortable with that scenario and you've got it dialed in. And so that when it happens for a baby, you're desensitized to it. Not that it is any less scary, but at least you know the steps. It's that motor muscle that goes through. The other, that alone, and everybody knowing what their deal is, everybody knowing what their strong point is, coming to that team game, then you do a much better job of that with that baby and with that, frankly, brand new life, and oftentimes with the parents right there. So the neonatal simulations have been super helpful. The other thing that we have done, we're the first in the country to do this, when you say a picture tells 1,000 words. So you're in the middle of a resuscitation and you're calling down a hospital for sick kids for help and advice in getting this baby stabilized and ready for transfer. And they ask you something like, what kind of a bag are you using to ventilate the baby? And your brain just explodes because there's 3 different bags. You know you're using a good one, but what is the name of that bag? And it takes you away from what you're doing. So what we were able to do, and again, thanks to the donors from the foundation to do this, we are the first people in the country to have a visual link to the hospital for sick children. So if I have a baby that I have resuscitated and I need advice for, and sometimes, heck, if I just want somebody else to lay eyes on the baby, I can call through Critical. I'm hooked up with the neonatologist at Sick Kids via OTN. It's a big camera, or a big TV screen, and there's a camera on top, and they move everything. And they can see, I don't have to take my hands off the baby. They can see all of the monitors. They can see and hear everything we need to do, and they can tell us exactly what they would suggest doing. And I don't have to give vitals. I don't have to tell them what we're doing. I don't have to paint a mental picture for them with words when they can see it.
I'm going to go back to Dr. Devet for a minute. We've heard about some of the challenges that you and your colleagues are facing, and we know that as the first line of defense for all medical emergencies in our area, the emergency department has to be prepared to take on all types of cases. We also know that the nursing staff are in short supply. The medical staff and the nursing staff and the RTs are all tired. How are you managing burnout yourself and across the department that you're leading?
So first off, I think it's really important to acknowledge the nurses. In our hospital across Ontario, in my emergency department, they're the cornerstone of healthcare delivery. If you're admitted to a hospital, like, you're not cared for on a moment-to-moment basis by a physician, or if you're emerged through kind of a nervous 4 to 6 hour visit, you're not having a physician sort of be with you and handle most of the emotional components of it. We can do that in that time you have us, but for anyone who's been in the emerge, or, you get that doc and you have them, but, that stable person who's kind of shepherding you through as a nurse, which is in itself an exceedingly important job and a wonderful job to have to be there with those people. But you know, it's kind of a hard thing to talk about because everything else is like, everything's perfect. And we get to talk about something fun, but you know, right now it is really hard because if our merge was a roofing company, we would have stopped quoting or quoted astronomically high to avoid some of this work. Like it's hard for us to have the numbers to go with the volumes that we're seeing, right? So our community's doing wonderfully. Like people are moving here all the time. They're having emergencies in our community. They have primary care issues as well because maybe they've moved from a different town and they've had a hard time. So our volumes are going up and the complexity is going up in emergency care. And with that, specifically from the nursing side, the doctor side a little bit and some of the other sides, but specifically from the nursing side, we can struggle sometimes to staff it. And that's not unique to us, Jory. Like, there's no doubt that Ontario is growing, our population, a number of these towns is growing, nursing shortages are common. But the difficulty with a shortage in any workplace is it can make it hard to excel. So we just heard examples from Dr. Guscott and Dr. Yeates about like what it means to excel, right? And so we always want to make sure from a burnout standpoint that we've got the staff there, that when our nurses are there, we've got the full complement. When something comes in, we're rolling. Because we know how to roll, we've done it before. Just as a shout out, I was actually gonna answer this in your first one, but I didn't know how long to talk for, so I'm gonna bring in my second question. But you know, like an example of rolling, prior to the Humboldt bus crash, we had the largest known motor vehicle collision trauma in all of Canada in something like 2017, and I can't begin to tell you the amount of credit we got across Ontario for the unbelievable efforts we did to resuscitate those 8 people, 6 or 7 of which were intubated, 6 went down to sick kids, all survived, 2 went down to the ICU elsewhere, and that brought us through 8 months of morale from that. Like, I went to work after that, and I would walk, if I'm allowed, I can't stand it. I walk into work like this, like I'm part of an awesome team, we kick butt, and like you didn't have to say it, you just knew it, you knew it. Like we talked about it for 2 weeks or 3 weeks, and after that we didn't even talk about it, but we knew it, and it just kind of carried us through. And now we have that, but it's harder because we're feeling some of these barriers, again, not unique to our hospital, but we do have to kind of acknowledge that when our staffing is low, it's hard to feel like we're rolling. So what can we do? You can always lean into what you do well as it relates to culture and appreciation, bringing your best self. And I do think actually our nurses and doctors, I can speak most for the Emerge because that's my department, they bring their very positive best self. We usually are staffed quite well, but there's days where it's a little bit lower, but I'm almost a little surprised and in awe of how when it's a little hard to bring all of our resources, like 120% of what we need to a given day, they still have it. Like they still have the kindness and that like kind of gusto to say like you need me, I'm gonna be there and do this, which is like when you step back from it, it's surprising that some of, especially these nurses, docs as well, but especially these nurses, continue to bring such an unbelievable attitude in a job that's, you know, pretty difficult just as it relates to what we're seeing, the volumes that we're seeing. You also want to support them through staffing, but then also with some of the programs that Dr. Yeates and Dr. Guscott do. So as our docs and our nurses do SIMS. We're back post-pandemic to learning together, which has a social component to it, just being together outside of work, which is now something we're able to do. But then also when that comes in to say like, okay, we're on it, we're rolling, that sort of thing. It was, I think, harder, and I think a lot of organizations, you know, including I think many hospital organizations, when you're just trying to get through the pandemic, you're not into your front foot innovation mode, and I think we're kind of coming out and getting back into that a bit. But I don't want to like sugarcoat it, Jory, and say like we're there, but you know we're not there. And I think specifically from a nursing standpoint, when you look forward for the next 5-10 years, what are we going to have in Collingwood, in Ontario, globally to meet the healthcare demands? Like, are we going to have that staff? It will remain burnout and staffing, which kind of go hand in hand. An issue that we constantly need to be combing over and addressing and working on, because it's not an easy thing with an easy solution, if I can be perfectly honest.
And as you can see, Dr. Yeates has run back to deal with a baby. This is real life theater. Mike Lacroix, you came into your role as CEO of the hospital during a difficult time, post-pandemic, but a difficult time. Do you have any ideas about how the community can support healthcare workers in the hospital in general through this time of burnout?
Thanks, Jory. Absolutely. So there's a lot that we can do as a community. I think a lot of resonates with me what Greg just said, especially with our nursing staff, especially with our frontline staff. And if you recall, about 3 years ago, we were all on our front porches and we're banging pots and pans, right? And if you fast forward, I mean, just coincidentally, the WHO, the World Health Organization, has declared the pandemic over. Obviously, the disease is still among us, and we need to cope and deal, but it's officially over. But if you think about it, 3 years after the pandemic has started, I would argue it's actually more challenging today to work in a healthcare environment and to lead in a healthcare environment. So I think on the basic level, at the very basic level, recognizing our staff, like we did. I mean, I'm not suggesting we go knock pots and pans, might wake your neighbors up, but I would strongly suggest that if you know healthcare workers, if you see healthcare workers, just a thank you goes a long way. And that's sort of the starting point. And I think when you do come to the Collingwood G&M Hospital, or any hospital, or any care provider for that matter, just acknowledge that they are doing the best that they can with the resources that they have. And in our cases, in the physical constraints that we have in our existing building. And they're doing an amazing job at that. So that's sort of the recognition side. And then if you slide up that scale a bit, you start to look at how can we do some of the things that Greg talked about, really just having more fun in our environment. We haven't had the chance to have fun. We're starting to get that sense back. It's still going to take a bit of time, but that's really done through our wellness committees and events that we try to hold, and I know some of that is sponsored by the foundation and the generous donors. But the most interesting part, and I think the most impactful part for me, is when I go around and talk to our staff and ask them the question, like, what can we do? Right, like, because we have our constraints, we know that there's limitations, we just can't find 100 nurses, because I would hire them in a minute if we could. And the interesting feedback from them is they want us to invest in them. They want us to, I mean, a lot of folks have left, a lot of folks have retired, but a lot of folks have stayed. And those people are committed to this organization and this community. And I think if we invest in them, and it's through the things that we're doing with simulation and elevating their skill set, giving them the tools to bring our level of care to the next level, that's what they want. And it could be equipment, it could be training. A great example that's coming up is our MRI, and that's a service we have fought for and we are going to get. And I see it in our diagnostic imaging department. They're trying to replace a lot of equipment, but that MRI lift is something that's driving them, and they're focused, and they're very excited to be delivering this service that is net new to our community. So I think it's those types of things that we'll have to continuously do over the next 5 to 10 years, as Greg said, because it's not going to end overnight. But I think that gives us a fighting chance of supporting our staff.
Mike, what do you see as the future of healthcare in Collingwood and across the province?
So that's a big question. Yeah, I'll be honest, I think we've been driving at this and focusing on this for a while now, but it's going to start to resonate as we get closer and closer to our new hospital. So we're part of the South Georgian Bay, Ontario Health Team, and so we're the hospital that's in that partnership, and we have partnerships across the continuum of care. And our vision as a collective is to be the healthiest community in Canada. So to me, it's really health-centered community, and I think that's something that the province and a lot of communities in our country are trying to replicate. And we already came up with that. We're working towards it. And what does it really mean? It means that we can provide those services local to home. It's not all going to be in the hospital. We're going to partner. We have great community partners, and I do think it actually starts with our family physicians. And having them at the center. They're typically your first entry point into the healthcare system. So the partnerships we have with them, the connection points we have from sharing of information and data, the planning, we're here to provide a very specific acute care service. So I think it's that's sort of the focus, and having patients at the center, having patients as a partner in care, having access to their information, and being informed. I think that's sort of the nutshell of it, in addition to a lot of the preventative, the education, informing people, how can we be healthy, exercise. I think our municipalities, our counties, and even at the provincial level, we're finding ways to make this a healthy environment that we live in. And so when you go into, well, how do we get that done? And the new building is absolutely going to be a catalyst for that. But it comes down to, I think, three things. We have investment in technology, and we're doing that, and we're going to continue to do that. It's going to enable us to work better with our partners, work well within our organizations, and even outside of our region. But the second is, we've already talked about people. We need to keep investing in our people so they can keep delivering the high level caliber care. And then partnerships. It's the focus on partnerships, and we know as an organization we can't and we shouldn't be doing it all. And we're going to be partnering with those who have that skill set and that ability. And what it does is free us up to do what we do well, which is the emergent care and the high acuity care. And I think the building and the Poplar Health and Wellness Village that we're hopefully going to be a part of will really be that enabler where we can start to be selective as to what is important and what we're going to do best, and we're going to do that in our hospital, but we'll have this real opportunity to do that as part of a larger village setting. So we're very excited. The vision is there, and we're starting to actually make progress on achieving that vision.
Lisi, I'm going to finish off with you. What do you see as the future of healthcare in Collingwood and beyond?
Great. Yeah. We're in a redevelopment process. Everybody knows this, and Mike has alluded to the structures and the buildings that are going to be beautiful, and they're going to facilitate teaching centers and lecture halls and simulation centers that are state of the art, and we're going to have all of those things. But I think the most important things are enhancing our people and the education. Collingwood is already known for its education. We run something called ICE camps, rural resident functions. We partner with our Rural Ontario Medical Program to provide some of these services. So people from all over Ontario come, and that's the future. We rely upon folks like Dr. Devet, Dr. Guscott, Dr. Yeates, and others to do what they do best, teach, draw people in, and become even more recognized as Ontario's Centre for Rural Learning, and using our partnerships and what we have in the natural environment of the mountain, the Wasagas, the local areas, that the Collingwoods, our other Clearviews, etc., that we can rely upon those local factors to leverage some of the skill sets. We've got a lot of great people here, and that means there's a lot of opportunities for additional innovation. And I love making announcements too, and so this is one that I'm excited about. Yes, actually they don't know it yet, so they're going to be a part of it, but they don't know it yet. But we will be launching what we call an innovation lab. And prior to the pandemic, we were working with, I was doing some training and whatnot in Harvard, and we looked at things like incubators and how do we get innovation and bring in private enterprise to mature certain types of private products and integrate them into the healthcare field. And so that kind of, COVID kind of killed a lot of that. But we're bringing a lot of this back and something that we're going to be launching called the Innovation Lab, which is going to be facilitating some of these types of ideas and activities and digital health, to artificial intelligence, to specific opportunities where healthcare practitioners can work with some of these activities and have learners come through and do certain studies and opportunities where we can grow some of this and become integrated, because that's the future. We have to lead that charge, and I'm very excited about that one.
This concludes the panel portion of this evening, but we have lots more to go, so please stay with us. I want to thank all of our panelists. As you can tell by Dr. Yeates' quick departure and the fact that Dr. Guscott is just chomping at the bit to get back to the OR.
to see if Gillian's going to call me.
That these leaders really put community in everything that they do. They wanted to be here today so that they could share the impact that you've had on their work. And we're very grateful to them for coming out. We hope you've learned a little bit about the innovation at CGMH, and I'm sorry we don't have an opportunity for questions this evening, but questions can be directed to us at the Foundation office. We would love to speak to you, and we can always connect you with one of the many healthcare leaders in the community if you would like to chat further. So we have more to come, but thank you for gathering around with us this evening, and enjoy the rest of the evening. Thank you.